Welcome again. We're gonna go through some renal emergencies and we'll see how fast we can get through it. You guys know why this slide is included. Now to get started with some pre-test questions. What are 3 medications that facilitate potassium entry into the cell? What are 3 medications that facilitate potassium entry into the cell? Number 2, what medication helps to stabilize the cell membrane and prevent undesirable depolarization during hyperkalemia? What medication helps stabilize the cell membrane and prevent undesirable depolarization during hyperkalemia? And then bonus points if you can identify the dysrhythmia that we are trying to prevent. Number 3, what is the most common cause of scrotal pain? What is the most common cause of scrotal pain? And then number 4, in testicular torsion, how long does the patient have before there begins to be irreversible ischemic injury due to the testicular parenchyma? Basically, number 4, how much time do you have before ischemic injury occurs during testicular torsion? So acute renal failure can be characterized by a rapid rise in creatinine, which is similar to a decrease in creatinine clearance. So if you're not clearing creatinine, that means you're having a rising creatinine level. Also, decreased urine output or lack of urine output is also indicative of acute renal failure, whereas chronic renal failure is characterized based on increased echogenicity on ultrasound, which I'll show you in the next slide, and it's also characterized by a smaller kidney. So this decrease in kidney size is caused by decreased function of the kidney, and once you stop using something, it becomes smaller. Think of not using muscles leads to small muscles. Same concept here in the kidney. So this next slide is going to be optional. It's not on the exam. However, I found it interesting comparing a good and a bad kidney on ultrasound, so I figured I'd describe it here shortly. So looking at the anatomy of a regular kidney, we have the renal parenchyma, which, if you remember, parenchyma means the functional unit of the kidney. It consists of a renal cortex and a renal medulla. And within the renal medulla lies the renal pyramids. And if you remember, the function of the pyramid is to transmit urine from the outer portion of the kidney into the renal sinus and down the ureter to be excreted as urine. Also note that the renal sinus contains fat, which will come into play when we're looking at the ultrasound here in a second. So to review some terminology, we have echogenic, which means a bright white, so the center portion of the kidney will be echogenic. Then we have hypoechoic, which is referring to a darker portion of the ultrasound. So if you look here, this echogenic white line, and then this slightly darker portion can be defined as hypoechoic. And then you have isoechoic, so that's two of similar color, so no change. So you could say that the liver and this portion of the kidney is isoechoic. So this red line here can be considered the renal parenchyma. So it goes from this echogenic fibrous capsule down to this echogenic renal sinus. So the sinus, if you remember, contains fat, and fat shows up as echogenic on the ultrasound. All right, and then you have this anechoic portion of the kidney, which is the renal pyramid. And if you remember, the renal pyramid contains urine, so urine appears anechoic on ultrasound. And you can see here there are multiple different renal pyramids, which is consistent with the image you see here. Okay. And then lastly, if you're comparing the good to the bad kidney, the good kidney, as you see, is larger, 11.2 centimeters versus 8.78 centimeters. Also, you could see that the bad kidney has a thin parenchyma, So this makes sense if you think of a damaged kidney, it's going to have less of a functional unit. So on the previous slide, when it said a bad kidney has increased echogenicity, it's due to a thinning of the renal parenchyma, which leads to just a disordered center of the kidney, and this is a complete distinction between this one. So it kind of makes sense when you're comparing the two. Hope that was helpful. So acute renal failure can be defined by decrease or lack of urine. So normal urine output is greater than 500 mLs in 24 hours, whereas oliguria is less than 400 mLs in 24 hours. And then a lack of urine or anuria is less than 50 mLs per 24 hours. So if you remember, 500 is normal, you cut off a 0, 50 is no urine, and then if 500 is normal, less than 500 would be abnormal, which is oliguric, which technically is less than 400. So 5, the next number down is 400. Diagnosis of renal failure can be obtained via an H&P examination, checking the blood, urine, and then several various radiologic studies, depending on suspicion. Now, treatment for renal failure is going to be pretty simple. If hemodialysis is an option, and it doesn't say first-line treatment, chances are hemodialysis is a good possibility of being the answer. However, just be careful of whether you ask for first line. So first line for pulmonary edema, if it's pulmonary, it's going to be ABCs. And if it's an acidotic problem, if they have a pH of 7.1, you're going to have to fix that via sodium bicarb or some form of metabolic means. If it's a fluid mismatch, obviously give them fluids. If you have an obstruction of the ureters, you could insert a Foley catheter, makes sense, bypass that obstruction. And then hyperkalemia we will get into here shortly. So I'm fairly certain there will be some form of question from this slide. So just bear with me and I'll try to work through each of these medications. So let's start first with hemodialysis. I think hemodialysis is always going to be an option for renal failure patients, and in this case hyperkalemia. However, it is invasive and probably saved for the more critical patients, okay? And then next we have calcium gluconate. Now pay attention to the names here. We have calcium gluconate specifically, and it's not referring to any other form of calcium, okay? So calcium chloride, calcium carbonate, although calcium chloride can be used, calcium gluconate is preferred in these cases. So the way it works is it stabilizes the cell membrane. So a cell membrane that is stabilized is least likely to prematurely depolarize. So what happens in hyperkalemia, patients are at increased risk for lethal ventricular arrhythmias, namely VFib. So by stabilizing the cell membrane, the patient is less likely to enter these lethal dysrhythmias. So note that this occurs quickly, so it is good for acute treatment, but it does not treat the underlying cause. So it can prevent death from dysrhythmia, but does not get rid of the underlying hyperkalemia. So to get rid of the hyperkalemia, you have the next two best options, I would say, are insulin as well as albuterol. So when you're giving insulin, you must also administer glucose to prevent hypoglycemia. So the mechanism of insulin is through the sodium-potassium ATPase pump. Now, if you remember, you have a salty banana in cells. So potassium is intracellular, and you have salt or salty banana, so sodium, extracellularly. So to push potassium into the cell where there's a higher concentration requires active transport because you're going against the concentration gradient. So you require an ATPase pump, which is a form of active transport. So insulin stimulates this ATPase pumps and allows for potassium to enter the cell. And this is a similar mechanism of albuterol, which is a beta-2 agonist, which works in a similar way. Now, sodium bicarb is also an option for treatment. However, it is the least effective of the least effective compared to albuterol or insulin. So it works by increasing the blood pH, which also forces potassium back into the cell. And then lastly, you have K-exhalate. K-exhalate works by exchanging sodium with potassium in the intestines. So since it works through the intestines, it is a delayed onset. So it takes about 2 to 4 hours. So it's not going to be the answer for which is the first line for acute management of hyperkalemia. For that answer, I would look for insulin or albuterol as the answer. Okay, hope that was helpful. Now moving on to hematuria, you have gross hematuria, also known as macroscopic hematuria, and then microscopic hematuria. So you have medical and surgical causes of hematuria. So medical causes are also nephrologic causes, so these occur in the nephron itself or in the kidney itself. And causes of this can be items such as blood dyscrasias or bleeding disorders. You could have interstitial nephritis. Remember, itis is the one that leads to blood. And then you could also have some form of renal vascular disease. Now, the urological or surgical types of hematuria are going to be largely caused by some form of cancer, tumors, also possibly stones and or UTI. So the presentation of hematuria is obviously going to be blood in the urine. Anemia is possible, albeit very rare, and this only occurs if it's severe bleeding. And then obviously the workup of these patients, if they have hematuria, you need to look at their urine, so urinalysis, get a culture, get cytology, and then you're going to look at the ultrasound of the kidneys. Alright, so the pain of renal colic presents as a sudden onset of pain, and it's going to be radiating to the groin, which makes sense because it's going to be going from the kidneys radiating down to the groin. And this position can change over time. However, don't utilize the pain as indication of where the stone is located. And it really does present with a distinct pain presentation. I've seen grown men cry, they're vomiting, they're just super uncomfortable. You see someone moving around, you get a pretty obvious, it looks pretty obvious like kidney stones or renal colic. And then the differential diagnosis is basically anything from below the diaphragm down to the bladder. Just name it, it's a differential. Working up these patients is going to be pretty simple. H&P, I mean, it's a pretty clinical presentation. Pregnancy test in women, as well as urinalysis. Now, diagnosis of renal colic is a little bit of a, I'm not really sure what he's going to want, essentially. So I looked it up and up to date. Non-contrast CT is the recommended first line for investigating renal colic. And it states that abdominal ultrasound should be used only if non-contrast CT is unavailable or if the patient is pregnant. It also said that radiologic KUB is basically useless, and then MRI is not really that great either. It's super expensive and would only really ever be recommended only in pregnant patients. So basically it comes down to whether he's going to want ultrasound or CT. I'm going to put CT on the exam because I have the scientific evidence behind it, which means it's probably going to be wrong. But that's that. In the acute management of ureteric stones, you're going to be treating the pain as well as trying to get the stone to pass. So he has here IV Toradol as the choice for pain. So if that's effective, then great. And then also just fluids, lots and lots of fluids for the patient, IV fluids particularly. And it does state here that 95% of stones measuring less than or equal to 5 millimeters are more than likely going to pass spontaneously. And this can be assisted by plenty of fluids in the circulation. So there's going to be several reasons that you're going to want to intervene and actively remove the stone. So first is going to be if the pain is unresponsive to several different types of analgesics. If there's a fever because you're worried about sepsis. Also, if the renal function is going to be impaired due to the size of the stone. And lastly, if the obstruction is unrelieved for greater than 4 weeks, that's going to be indication to remove the stone. Now for urinary retention, we have several different causes and some that are specific for both men and women respectively. Now for men, most causes of urinary retention are going to be related to the prostate in some form. Whereas in women, it's going to be either pregnancy induced, such as post-surgery, or pelvic prolapse, or there could be a urethral stricture. Also consider pelvic masses, so any masses specific to the female genitalia as well as reproductive organs. And there are also several different causes that are unrelated to sex, so they can occur in both sexes, and there's a list here, and you can read it at your own leisure. Now, treatment of urinary retention is simple. You can't get pee out, so you stick a tube in to bypass the urethra. So you could do urethral catheterization, or you can do a suprapubic catheter. And then, of course, the late management is to find the underlying cause and treat that itself. Now, there are several different causes for scrotal pain. Now, the most common is going to be epididymitis. So the most common is epididymitis. However, the most serious is going to be, of course, torsion of the spermatic cord, or testicular torsion. So as we know, testicular torsion is a surgical emergency. You could have irreversible damage as early as 4 hours after blood is cut off from the circulation. So presentation is going to be pretty obvious. It's going to be acute onset of severe scrotal pain. It's going to be associated with nausea, vomiting, and there will be no bladder symptoms usually. Physical exam findings can also be obvious for torsion. You're going to have an absent cremasteric reflex, and you may also see a acute hydrocele, or a massive, huge ball. You're going to have a huge ball sac unilaterally, essentially. Now for imaging, you can do a color Doppler ultrasound. This is very good to assess for blood flow to the testicle and could aid in diagnosis. Now next disease up, we have priapism. Priapism consists of a erected penis that remains erected for greater than 4 hours. Now note this erection is not related to or accompanied by sexual desire. And there are multiple causes. Most actually are idiopathic. However, there are secondary causes such as drugs, trauma, or neurological causes. So to diagnose priapism, you just really need your eyes. It's pretty obvious. You can do H&P. You're also going to want to pull a Nick and get that DRE. Now, treatment of priapism is dependent on the type. It can be either medical or surgical, and its treatment also depends on the underlying cause of priapism. And then, of note, it is very important to warn these patients that there is a possibility of impotence due to this condition. Now, renal trauma can occur via either blunt or penetrating injuries. Now, there are two options when it comes to renal injury. First is an ultrasound, which allows you to first determine if there are two kidneys. You could identify if there's a retroperitoneal hematoma, and you could also determine an absence or presence of blood flow through the appropriate vessels. The disadvantage basically lies in the inability to identify or localize specific traumatic areas within the kidney, so you can't determine if there are any tears or any collection system injuries, etc. So this determination requires a contrast-enhanced CT, which, as it says here, is an imaging study of choice because it allows for accurate imaging of the kidneys as well as other intra-abdominal structures, which is important because abdominal trauma typically involves more than just one organ. Now for injuries to the bladder itself, these are a pretty obvious presentation, so you're going to have a triad of symptoms. Now these symptoms include suprapubic pain, which is the location of the bladder, so that makes sense. You're going to have difficulty urinating because you just had a bladder injury, and also this injury is going to lead to trauma to the bladder, which will result in blood in the urine because of where the trauma occurred. Now, diagnosis is through abdominal ultrasound with a focus on the bladder, and then you're going to want to seek immediate surgical consult for these patients. Now, for testicular injuries, there's going to be three main categories. You have blunt trauma, which most common affects just the unilateral side, so you're not typically going to have both testicles involved. To diagnose, really the only thing you need to check for is to make sure that there is appropriate flow of blood, so this can be occurred through flow Doppler, and treatment is typically going to be supportive, whereas penetrating trauma will typically involve both testicles, and of course you're going to want to do a little more detailed investigation because of the nature of the trauma, and of course this is going to require some form of surgery. Now lastly, you have degloving injury, which is pretty obvious what a deglove is. It's removal of the skin into like a flap. Basically, these are rare. They're commonly occur through work-related injuries, so getting stuck into some kind of machinery. Degloving diagnosis uses your eyes, pretty obvious, and treatment is going to be, of course, surgery. Now for the answers to my pre-test questions, we have the three medications that facilitate potassium entry into the cell. Those three medications are going to be insulin plus glucose. Number 2 is going to be albuterol. And then number 3 is going to be sodium bicarbonate. Alright, for number 2, what medication helps to stabilize the cell membrane and prevent undesired depolarization during hyperkalemia? That medication is going to be calcium gluconate. And remember, the one that you're trying to avoid is VFib. So calcium gluconate stabilizes the membrane, prevents fatal dysrhythmias, notably VFib. Number 3, what is the most common cause of scrotal pain? Most common cause of scrotal pain is going to be epididymitis. And then lastly, you have 4 hours before you can begin to see ischemic injury due to testicular torsion. Well, I hope these videos are helpful. I've included a link to the PDF version of this PowerPoint if you guys like the changes that I've made to them. Either way, good luck.